In the management of newly diagnosed myeloma patients non-eligible for autologous stem cell transplantation, it has been established that maintenance therapy following initial treatment prolongs progression-free survival as well as overall survival in this population. However, at the present time, there are no agents specifically approved as maintenance after different induction therapy for this population. And the information we have about maintenance is basically derived from continuous therapy based on immunomodulatory drugs. So definitely, I think that options that could potentially complement the induction regimes with excellent toxicity profile are needed and could be evaluated in this patient population. Ixazomib Ninlaro is an oral proteasome inhibitor that it is going to target different subunits from the proteasome inhibitor, resulting into anti-tumor direct effect on the plasma cells. Ixazomib is a proteasome inhibitor that there had been developed for the management of patients with multiple myeloma, other proteasome inhibitors, but the differential features for Ninlaro in comparison with the other proteasome inhibitors is basically based on the oral administration, because it is given just once per week, oral administration with an excellent safety profile. And I think that these are the three main features that we can remark for Ninlaro. The TOURMALINE-MM4 study is a phase 3 randomized, double-blind, placebo-controlled trial that it is focused on the evaluation of the safety and efficacy of ixazomib as maintenance therapy in transplant-eligible newly diagnosed myeloma patients following standard of care induction therapy. This is important because this means that patients with myeloma of new diagnosis, they can potentially receive whatever induction regime. And if this patient received at least 6, 12 cycles of whatever standard of care as induction, and they achieve at least partial response, these patients would be available to be included in the TOURMALINE-MM4 study, and patients were randomized 3-2 to receive ixazomib versus placebo. Ixazomib was given at a dose of 3 milligrams on days 1, 8, and 15 of 28-day cycles during the first 4 cycles, and since the cycle number 5, the dose of ixazomib could be increased up to 4 milligrams, and continuing receiving ixazomib every week for up to 24 months or until progression or an acceptable toxicity profile. And the placebo arm received placebo in the same scheme. 706 patients were included in this study, and 425 patients were randomized to receive ixazomib, whilst 281 patients were randomized to receive a placebo. And in this study, the stratification factors were induction regimes, PI containing versus non-PI containing regime. What is important because ixazomib is an oral proteasome inhibitor, ISS disease stage, age, younger or older than 75 years, and response to initial therapy, CR or VGPR versus PR, because according to the inclusion criteria in this study, patients had to be achieved at least partial response to the standard of care induction regime. The primary endpoint of this study was progression-free survival from randomization to receive ixazomib versus placebo. A key secondary endpoint is overall survival, and additional secondary endpoints include response rate, as well as time to progression, progression-free survival 2, long-term safety and tolerability, as well as quality of life. The primary objective of this TOURMALINE-MM4 study was progression-free survival, and this trial met its primary endpoint because ixazomib as maintenance resulted into a significant benefit in terms of progression-free survival in comparison with placebo. The median follow-up for progression-free survival is 21 months, and ixazomib as maintenance was able to reduce the risk of progression or death in the ixazomib versus placebo group by 34%. The median progression-free survival in the group of patients receiving ixazomib as maintenance was 17.4 months, approximately 1.5 years, whilst in the placebo group, the median progression-free survival was 9.4 months. The hazard ratio for progression-free survival was 0.65. In terms of a safety profile, following by the efficacy, this study did a landmark analysis to the date of induction therapy. This means that this progression-free survival included the time from starting induction therapy until progression and or death occurred. And when we evaluated this progression-free survival, the benefit for ixazomib as maintenance was maintained, and the median PFS for ixazomib was 26 months versus 20 months for placebo, with a hazard ratio of 0.65. From the efficacy point of view, I think that it's also important to remark that the benefit was observed across the different subgroup of patients. And I think it's important to remark the significant benefit observed in patients older than 75 years, as well as in patients with advanced stage of the disease, ISS3, and also the significant benefit observed in patients achieving complete response or VGPR after the standard of care induction. The safety point of view was favorable for ixazomib. It's true to say that as ixazomib was allocated in the experimental arm and placebo was the control arm, and this means that patients were not receiving any active therapy. It's true that the rates of serious treatment emergent adverse events, as well as discontinuation due to treatment emergent adverse events, were slightly higher with ixazomib versus placebo. But I would like to remark that most treatment emergent adverse events were grade 1 or 2, and if we have to remark the most relevant adverse events related potentially with ixazomib and reported in at least 5% higher with ixazomib included nausea, vomiting, diarrhea, RAS, peripheral neuropathy, and pyrexia. But overall, I would say that the safety profile for ixazomib is consistent with the safety profile we have already seen in other trials in which ixazomib was incorporated, and tolerability is good. Ixazomib was first evaluated in the relapsed and refractory setting, in relapsed and refractory myeloma after 1 to 3 prior lines of therapy in combination with lenalidomide and dexamethasone. And this combination resulted also into a significant benefit in terms of progression-free survival in comparison with lenalidomide and dexamethasone. And this is a standard of care that we can use in this population. But ixazomib has been also evaluated in the upfront setting as part of maintenance therapy, but in the transplant-eligible population. And again, the trial compared ixazomib versus placebo in newly diagnosed myeloma patients after autologous stem cell transplantation. This trial met also its primary endpoint, significant prolongation of the progression-free survival with good safety profile, but it's true that approval for ixazomib as maintenance in the transplant-eligible population is pending. Another trial is also conducted in the transplant-ineligible population in the upfront setting in combination with lenalidomide and dexamethasone, and the control arm is lenalidomide and dexamethasone alone. This study has right now a large follow-up, and unfortunately, the trial did not meet its primary endpoint, significant benefit in terms of progression-free survival, but I think that it would be important and very interesting to evaluate in detail this study, because I think that there could be specific populations that could have a significant benefit from the treatment with ixazomib in combination with lenalidomide and dexamethasone in the upfront setting. And so I think that these are basically the TOURMALINE studies in which we are right now involved with the results or with results that are going to be available in the upcoming months. But I would say that the clinical development plan for ixazomib will continue.